Yes, ma'am, we are live. We can begin.
Good evening and welcome to this IFS webinar series. Today we're going to talk about ovulation induction. What are the nuts and bolts? What are the finer points? And we know that ovulation induction is one of the first level of treatment that is done for infertility, and it's done across the board by all gynecologists. Now, before I begin, I would like to thank Dr. Sudha Prasad and Dr. Nina for giving me this kind invitation and allowing me to address you people on this platform. So to begin with, let's look at the structure of the talk. I'm going to look at the definitions and the indications of ovulation induction, and then look at the endocrine control of folliculogenesis, because if you know that, then you can fine tune the medication that you're going to use so that it's most efficacious and there are less complications. We'll look at cycle requirements or peculiarities in PCOS, unexplained, and hypogonadotrophic hypogonadism, because these are one of the three main indications for which you will use ovulation induction. We'll see how to monitor the patient, what are the drugs we should use for inducing the LH surge. Is gonadotrophic agonist, GnRH agonist or antagonist important in ovulation induction and IUI cycles? We need to understand that, and whether there is really a need to do or give luteal phase support during just simple ovulation induction cycles. Now, before I go any further, I think it's very important to emphasize the role of basic evaluation even prior to starting any kind of ovulation induction. Please don't forget to do a semen analysis. And in today's day and age, please ensure that you do tubal evaluation. In a young PCOS patient, you may give her one cycle of ovulation induction without doing a tubal evaluation. But subsequently, there is really no excuse for not doing tubal evaluation before exposing a woman repeatedly to drugs. So looking at the definition, ovulation induction, if you look at it very technically in technical terms, means inducing ovulation in an anovulatory woman, which is WHO group 1 and 2. And this is the hypogonadotrophic, hypoestrogenic anovulation, or the normogonadotrophic, normoestrogenic ovulation. However, it also broadly covers ovulation augmentation. That means when we give ovulogens to women who are already ovulating as an unexplained infertility, and also covers superovulation for IVF, but we are not going to look at that aspect today. Now, the causes of anovulation can be hypothalamic, they can be pituitary, which is mainly the hyperprolactinemia, they can be at an ovarian level, and other endocrine factors. So if you look at the causes of infertility, what you really see are that ovarian dysfunction takes up about 21% of this group. And then what you also see is that we use ovulation induction in IUI as a first-line treatment for unexplained infertility and for male infertility. So more than about 70% of infertile patients are going to receive ovulation induction in some form or the other. And therefore, it's really, really very important to understand the endocrinology of the menstrual cycle and how to use these drugs, because they are going to impact your hypothalamo-pituitary ovarian axis. Now, at puberty, there's maturity of this axis. The GnRH pulses increase. They lead to FSH-LH secretion from the pituitary and to recruitment of the FSH-sensitive follicles from the ovary. Any alteration in this would lead to anovulatory cycles, and the clinical presentation is very variable depending on the degree of abnormality. It can be from complete amenorrhea to oligomenorrhea, oligoovulation, and to simple just luteal phase insufficiency, and that's the bottom of the ladder. When you look closely at the menstrual cycle, and what you can see here is as the estrogen, estradiol, and progesterone levels fall in the luteal phase, the GnRH pulses increase and the FSH starts rising. Now, this reaches what is called a threshold value and then gets maintained for a certain period of time, which is known as the FSH window. Now, the rise in FSH initiates, or the FSH threshold initiates growth of the follicle, and the FSH maintenance for a particular period of time will recruit the initial cohort for growth. Then as the FSH levels increase, the estradiol from the follicles increase, and this rise in estradiol leads to a little bit of drop in FSH and therefore the emergence of a dominant follicle with atresia of the remaining follicles. With the rise in estrogen, you will find a positive impact on the hypothalamo-pituitary axis, leading to an LH surge. And this LH surge leads to ovulation and secretion of progesterone. There is also a slight pre-ovulatory rise in FSH and progesterone, and this is thought to be important for final oocyte maturation. Another very important aspect to understand is the role of LH in folliculogenesis. We all know the two-cell two gonadotrophin theory, and the theca cells have the LH receptors. And in the early phase of the cycle, we have, due to the effect of LH, conversion of cholesterol into the androgens, androstenedione and testosterone. Now, these filter over to the granulosa cells where they are aromatized into estrone and estradiol. And all this entire concept is very important for follicular growth. So in the early phase of the cycle, LH is very important for increasing the intra-ovarian androgens and for growth and selection of the dominant follicle. And in the mid-cycle, it's important for the mid-cycle surge. That mid-cycle surge leads to resumption of meiosis and oocyte maturation, expansion of the cumulus oocyte complex, and rupture of the follicle. Thereafter, LH maintains the corpus luteum and allows the progesterone secretion to happen. And if pregnancy were to ensue, it allows for maintenance of the pregnancy. So you can see what an important role LH has in folliculogenesis, and it should never be ignored. So the important concepts to go back are the FSH threshold, which allows for initiation of follicular growth, the FSH window, which allows for cohort recruitment, the LH window or ceiling, that means this minimum amount of LH which would be important for the androgen substrate. And then there is also a ceiling level to LH, which is supposed to be over 5 international units per liter. And this, if you have too much of androgens, then the intra-ovarian or intrafollicular estrogen to androgen ratio gets disturbed, and your follicle may go into atresia with the oocyte also, the development tends to get compromised. So therefore, even the LH levels need to be within a certain framework to be able to give you the absolute good follicular growth and intrafollicular androgen estrogen ratio. The LH surge, of course, we know triggers ovulation. So then what are the drugs that we will use for ovulation induction? On the oral, when you give oral drugs, you need a functional hypothalamo-pituitary ovarian axis. And the oral drugs we use are the anti-estrogens, clomiphene citrate or tamoxifen, and the aromatase inhibitors, letrozole. The injectable agents do not necessarily need a functional HPO. And you can have here, these are the gonadotrophins. You can have the urinary HMGs, which contain both FSH and LH. And this is important because in hypogonadotrophic hypogonadism, you need both the hormones. You can have pure urinary FSH, you can have recombinant FSH and recombinant LH. You can also then give a combination of the oral and the injectables for ovulation induction. Now, there are certain adjuvants which we use, and this is specific to polycystic ovarian syndrome. And these are the insulin sensitizers, of which metformin is the more commonly used and has been used for long now. You have the inositols and even the N-acetylcysteine, and there are many others, but these are somehow the more important ones. You also have bromocriptine, which is specifically used to bring down the prolactin levels in hyperprolactinemia, and thereby allow the ovulation to resume, which has gotten arrested with the high prolactin levels. What are the drugs we use to trigger ovulation? This is HCG, which has been used very routinely, and GnRH agonist, which has started being used since the last few years. Very effective ovulation agent, but we'll go into the details of this later. Then there are the drugs to prevent premature LH surge, and these are the GnRH analogs, the agonist, and the antagonist. Now, the most common indications for ovulation induction are polycystic ovarian syndrome and hypogonadotrophic hypogonadism in the anovulatory patients. And in the ovulatory patients, it is unexplained infertility. And ovulation induction and IUI is the first line treatment in these patients before we move on to bigger things like IVF. Now let's look at the key issues in hypogonadotrophic hypogonadism. The first most important thing is the HPO axis is not working, and you need both FSH and LH to be provided from outside. So there is no GnRH pulses, and therefore no FSH LH. So what do? We provide either GnRH out in a pulsatile manner, which is not universally available. So what is more easily available is the injectable FSH and LH, and this together as HMGs, or if you're giving recombinants, then both have to be given together to stimulate the ovaries and allow for production of the eggs. So what is important here? What is the key point? The key point is you have to find or define the FSH threshold, because if you go below the threshold, if you're not given enough FSH, the egg initiation of development is not going to happen. And if you also need it, to be there for a certain amount of time so that you have monofollicular development, so you can't give excess and you can't give it for longer time. So dose titration and dose stabilization are the two tricky and most important things when you're looking at hypogonadotrophic hypogonadism, because believe me that even these people will go into ovarian hyperstimulation syndrome if you have not controlled the dose. There is a need to initiate the LH surge. Now remember that this axis is not working, and therefore you cannot give GnRH agonist, and only HCG will work. So HCG, when you're dealing with hypogonadotrophic hypogonadism, to initiate the LH surge and ovulation. Luteal support is important, though one would say that you can actually get away without giving it because the corpus luteum is effective. But having given so much of injectable medication with the HPO axis not really functioning properly, you don't want all your work to go for waste, and therefore it is important to give luteal support if you don't want a short luteal phase. PCOS. Now this is the most, this is the maximum number of patients you have is PCOS, and that's where you're doing ovulation induction. Now remember that the HPO axis here is intact, but what is upset is the endocrine balance. You have an increased androgen, you have lower FSH values, you may or may not have high LH, and the estradiol levels are slightly raised. So what you have is high intraovarian androgen, and this leads to follicular atresia. The lower FSH and higher E2 leads to a follicular arrest. So you can see all these antral follicles here. They have FSH receptors, but because the FSH levels are not good enough, therefore, and the higher estradiol level not allowing for further growth, they get arrested at this stage. And the recruitable pool of follicles, that means these follicles with FSH receptors, are increased 6-fold in PCOS patient. That means if the moment you go into that threshold dose, all of this is going to start growing. And that is the biggest problem in PCOS. Also remember that some of these follicles will have an enhanced sensitivity to FSH and LH. In this entire group that is there, some follicles may be more FSH sensitive than others. So you will have those growing even more and a smaller bunch growing after that. So again here, what we have to do is define the FSH threshold, which will allow for growth of this, something from here. You want only 1 or max 2, but that is the trick. How do we get that? And to do that, your FSH window needs to be very narrow. You have to find the threshold and you have to see that the window is narrow so that you have something like this, monofollicular development, and not something like this, which is going to definitely land you in ovarian hyperstimulation syndrome. Now, insulin sensitizers are helpful in increasing insulin sensitivity, decreasing the intravariant androgens, and thereby helping in ovulation. The AMH levels are very high in PCOS patients, and it has been seen that if the AMH levels are are above 7 nanograms, then you will need much higher doses to overcome this block that is happening at this level. Now, what about the LH surge? Well, if you have a picture like this, it's better to give the agonist to prevent ovarian hyperstimulation syndrome. But if you have a picture like this, you can very safely give a human HCG, and there's no problem there. So far as luteal phase support goes, again, as I said, since we are putting the patient through all of this, most of us end up giving luteal phase support. However, it is not really essential when you're just using simple oral medication to actually give additional progesterone during the luteal phase. Unexplained infertility. Now, what happens here? Your HPO axis is totally functional. Patient is actually ovulating. So why are we giving her ovulation induction drugs? The aim is to actually increase the egg number a little bit, maybe improve the endocrine milieu, maybe address simple corpus luteal insufficiency, and thereby try and improve the pregnancy rates, because 20% of patients may conceive on this first line of treatment, which is ovulation induction and IUI, and they need not go on to more complicated things like IVF. Remember, ovulation induction alone is not effective in unexplained infertility. You have to add IUI to it before as a first line treatment. Now, you can give both oral drugs and injectable or the two together. And again, as I said, luteal phase support is generally given because I think to make the physician more comfortable rather than the patient. Now, a Cochrane review of 2019 suggests that whether in unexplained infertility, there is really no difference in live births between expectant management versus just ovarian stimulation versus IUI versus OS plus IUI versus IVF. However, if the infertility is more than 2 years or the maternal age is advancing, then you will find a benefit, and you should move on to this first line of treatment at the earliest. Let's look at the advantages and disadvantages of the drugs that are used. We know that clomiphene citrate binds to the estradiol receptors in the hypothalamus and pituitary, and thereby it blocks the estrogen, their sensitivity to the estrogen that is in circulation, and they start by secreting FSH and LH. This stimulates egg formation from the ovary. Now remember that this is a false sense of lack of estrogen that is there by the body, because the estrogen is there. So you have this estrogen plus the estrogen, excuse me, plus the estrogen that is secreted by the growing follicles. So therefore you have a supraphysiological level of estrogen in the circulation. And that is why in clomiphene, you will have multifollicular development. It is far more common. However, it also has an anti-estrogenic effect on the cervical mucus and the endometrium. Now, you generally start with a dose of 50 milligrams per day, and you can go higher, especially if it's an obese woman. Better to start with 100. Majority of people respond with 100, but you can increment the dose. They can titrate the dose up till you find what is the lowest effective dose for ovulation. People have gone on to a maximum of 200 milligrams per day for 5 days or even up to 10 days. Now, the ovulation rates are good, 70%, but the pregnancy rates are much lower. You have a multiple pregnancy rate, which is high, and a miscarriage rate, which is about 20%. Now, 20 to 25% of these patients whom you're giving clomiphene will fail to achieve ovulation, even with the highest doses. And then you've done a couple of cycles, it hasn't happened, it's best to move or to change. In another 60%, ovulation is achieved, but they may either have persistently thin ovulation and therefore not conceiving, or fail to conceive despite everything else being normal, and then again, you need to move on. In patients who have thin endometrium on clomiphene, but who are ovulating well, you can try tamoxifen, which is given at 20 milligrams per day for 5 days, starting from day 3. You can go up to 40. It gives you a beautiful endometrial lining, very nice ovulation. And in fact, personally, I prefer it over clomiphene. I hardly ever give clomiphene because it is breast protective. And we know there have always been concerns off and on of the relationship of clomiphene with breast cancer. So why not give a drug which works in the same manner, but is also protective to the breast, especially if there is a family history of breast cancer. The pregnancy rates are very similar to clomiphene. Now, one of the greatest disadvantages with clomiphene is its anti-estrogenic effect. You will find women coming in complaining, who have been on multiple cycles, coming in complaining of vaginal dryness, itching, discharge. 15 to 50% will have a thin endometrium, which is non-responsive to E2V. And let me tell you that it takes many, many cycles for this effect to go away and for the endometrium to actually start rebuilding to its natural thickness. So that is one of the disadvantages. The higher incidence of miscarriage is thought to be because the uterine blood flow is lower during the luteal phase. It has a direct harmful effect on the oocytes, and the high levels of estradiol actually interfere with integrin expression in the endometrium and interfere with endometrial receptivity. So these are some of the problems which are associated and which are thought to be the reason for increased incidence of miscarriage. Now, the side effects are the usual one with cyst formation, etc. But one which I want to point out and which I want you to think about is blurring of vision. Now, this is a very serious side effect. It happens very rarely, but remember, the mind does not know, or the eye does not see what the mind does not know. So if you don't know that this is related to clomiphene, you will keep on giving the patient clomiphene and really may lead to blindness, which has been reported. And I have personally seen patients with this complication. So please remember that it does occur and you must take note of it if the patient complains. Going on then to aromatase inhibitor, this came up somewhere in 2011. It was brought into practice, and what it does basically, letrozole binds with the heme component of the cytochrome enzyme P40, which converts androstenedione and testosterone into estrone and estradiol. So what happens then is that the estradiol levels go down in blood and the androgen levels increase in the ovary. So therefore, letrozole is acting at two levels. One, at the level of the pituitary, where because of the decreased estradiol circulation, the FSH starts getting secreted because the negative feedback is, the positive feedback is there. And then in the ovary, what it does is actually it increases the androgens within the ovary, and the increased intraovarian androgens lead to increased follicular sensitivity to FSH. They also stimulate insulin growth factor and other autocrine and paracrine factors, which then synergize with FSH and promote folliculogenesis. It has a shorter duration of action, so that by the time on day 7 of the cycle, the effect has gone, the estradiol levels start rising again, so that they are able to induce the LH surge in the mid-cycle. However, for those of you who have ever looked at estradiol levels within the cycle, you may have noticed that the estradiol levels are really, really, really low, sometimes even just 60 or 70. However, despite that, the LH surge is mounted and the patient does ovulate. Fortunately, it does not have any peripheral anti-estrogenic effects. You give it in a dose of 2.5 or 5 milligrams once a day for 5 days. You can give higher doses, 7.5, even 20 on single dose of 20 has been given. However, in increasing doses do not really help very much. They're not very effective. And it's very efficacious, great ovulation rates, very good very good pregnancy rates and lower miscarriage rates. However, please remember that letrozole resistance exists. It is a reality, and you will find some patients who will not at all respond to letrozole and may respond beautifully to clomiphene citrate. Now, one of the first comparisons which came out, this was in 2014, between letrozole and clomiphene, showed, it was a randomized controlled trial, it showed that you had higher live birth rates with of 27.5 versus 19, with a risk ratio of 1.44 with letrozole as compared with clomiphene. And similarly, the cumulative ovulation rate was much higher, 61% compared to 48% with letrozole compared to clomiphene in women with PCO. So far as miscarriage, pregnancy duration, neonatal complications, twinning, they all remain more or less the same. But one very important factor, which especially in PCOS we know, is the high BMIs. And if you look at these graphs, you'll see that with BMIs below 30, BMIs above 30, BMIs above 39, in all groups, letrozole performed much better in terms of live birth than clomiphene citrate. Another double-blind randomized trial, letrozole versus clomiphene citrate, was done in 2017. And again, letrozole, people who were on letrozole as primary treatment showed significantly higher clinical pregnancy rates. And the superiority of letrozole over clomiphene was proven. And not only was there a 40% increase in pregnancy rate, but there was also a shorter time to pregnancy. And that's, I think, the first time, first question that we are all asked when the patient walks in, how much time will it take to get pregnant? So with letrozole, we have a shorter duration in this. Now, studies have been done in the Indian population, excellent studies, which again showed that it was a very good drug, safe, and a better alternative to clomiphene, and we should consider it as first line of treatment. Now, those of you who are older will remember that there was a huge hue and cry about congenital malformation risk with letrozole. In fact, the drug was banned in India. And that led to a lot of studies, which in a sense was very good, because it was seen that you had actually more cardiac malformations and miscarriage rates and IUGR with clomiphene rather than with aromatase inhibitor letrozole. And we give clomiphene around, it's really given around as toffee. So letrozole in that sense is much safer for the fetus than clomiphene citrate. And this was again taken up in India as well, and with the same result. So finally, a Cochrane database study showed us, and this is I think 2019, I can't see it because I've got my face showing there. So this showed that letrozole, and this was almost 8,000 women, letrozole and timed intercourse improves the live birth and pregnancy rate compared to clomiphene and timed intercourse with or without adjuncts. And this was moderate evidence with an odds ratio of 1.68. Now, OHS is similar. There's no difference in multiple pregnancy rates or miscarriage rates, and these are all high quality evidence. With LOD versus letrozole, there is no difference, but the quality of evidence here is very low. Somehow this has gotten stuck. Okay. So finally, this was accepted as drug of first choice, and even by ESHRE, ASRM, and all the, our standard IFS societies. So what are the special indications for letrozole? There are some things where you'll be very happy to give letrozole, and this is in patients with endometrial or breast cancer. Either you're doing ovulation induction there, which is a bit rare, but you may be doing a frozen embryo transfer, and then it's best to actually induce ovulation with letrozole, keep the estradiol levels low, and you can do the transfer without putting the patient on too much risk of giving her high steroids in the form of estrogen and progesterone replacement. In poor responders, because it increases intraovarian androgen, it augments the effects of FSH, and of course, CC-resistant patients and the others, the anovulatory and ovulation augmentation, and that stands true for the other agents as well. So what's the algorithm? Letrozole, drug of first choice; clomiphene, drug of second choice; tamoxifen if you have a thin endometrium; and gonadotrophin then is the next logical step. But before we go on to gonadotrophins, which have a high risk of complications, can we try something else? And a combination of letrozole and clomiphene has been tried, and this was a randomized controlled trial where both the drugs were given. The rationale here was that clomiphene will act on the pituitary. It will allow for block off the estrogen receptors, and therefore FSH will get secreted. And letrozole action will be in the ovary. We'll make use of that action within the ovary, which increases the intraovarian androgens and increases FSH sensitivity. So maybe two together, we will get an FSH threshold, which will induce ovulation. And in this randomized controlled trial that was done for just about 70 patients, it was shown that the combination had higher ovulatory rate in PCOS women with an absolute 34% absolute difference. Now, this all very well. I don't know how many of you out there use it. I have used it on very rare occasion, and you can use it where you have resistance to clomiphene and then resistance to, letrozole. Maybe using the two together before you use gonadotrophin may not be such a bad idea. Going on to the gonadotrophins, you can use gonadotrophin alone, and you can do gonadotrophin with clomiphene with the oral agents. Now, the indications are hypogonadotrophic hypogonadism, where you have to give FSH and LH. And of course, you can then use it in all the other CC resistance, failures, unexplained infertility. Please remember that the protocols have to be very stringent if you want to avoid complications. You must do serial ultrasounds. You must look at serum estradiol levels if you don't want to get yourself and the patient into trouble. In the combination protocols, really it's a free-for-all. I've written this, that giving clomiphene or tamoxifen in the first 5 days and then adding FSH, LH to try and get to the FSH threshold. This is one way. Sometimes people give alternate days. Sometimes they start together. So it's free for all. You do what you feel comfortable with. But the important thing here is close monitoring, because what you're aiming to do is to get to the FSH threshold and then keep the window narrow. So as soon as you see your follicles going over 10 millimeters, ensure that you cut down on gonadotrophins, because that's the one you can control. The oral you've already given, you can't do much about that. So to keep the window narrow, cut down slowly on the gonadotrophin that you're giving so that you get the breakthrough of just 1 or 2 follicles. So you have good ovulation rates, which are 90%, and pregnancy rates which are in the range of 50 to 70%. But you can see here the OHSS is 2%, and multiple pregnancy rates are almost to the tune of 15%. Now, when we look at the gonadotrophin only protocols, you're looking at monofollicular ovulation. That's what you're aiming for. So the protocols here are the chronic low dose step up, the conventional step up, and the sequential step up, step down. And for super ovulation, you can use step down or step up protocols. Now, The chronic low dose protocol is where the first increase in dosage will happen after 14 days. Till 14 days, you give 37.5 or 75 and don't increase the dose. And then you can increase every week till you have a breakthrough follicle at 14 mm. Now, it's a very long protocol and mostly everybody gets frustrated with it. So you can do a conventional step up where you start with 75 and increase the dose by 75 every 5 to 7 days. Again, the risk here is of multifollicular development. The sequential step up and step down, you start with 75, increase the dose by 37.5 every 3 to 5 days. The moment you have follicle coming up to 14, maintain your dose. You have the follicle at 16, drop the dose, or you find, too many follicles, more than 2 follicles, which you are seen to be going above 40, drop your dose so that you have only 1 follicle or max 2 follicles going up. However, with all gonadotrophin protocols, let me tell you, it's really, really difficult to do that fine tuning to get that 1 single follicle. Invariably, you have multifollicular development and you're then stressing because the patient may go into hyperstimulation. The step down protocol is best kept for IVF. Here, you start with a higher dose because this is your presumed threshold dose. You have sort of presumed in your mind that, okay, this woman is going to start growing follicles at a dose of 150 of IU of FSH. And you start with that and then gradually go down. But again, even though it mimics physiology, but you cannot control the multifollicular development, it's bound to happen because you started with a presumed higher dose. It was not the natural threshold, but it was a presumed threshold. The next important, and over the years, this has happened with all, reps telling us this is the better HMG, this is the better FSH, but Cochrane has finally put a stamp on it and said all gonadotrophins are equally effective and safe, and further trials are unwarranted, whether it's recombinant, whether it's urinary, whether it's HMG or FSH. There is no difference in clinical pregnancy rate, live birth rate, miscarriage rate, multiple pregnancy rate, or OHSs. So please use what is relevant to you in terms of cost and convenience. The benefits, of course, with gonadotrophins are that you increase the pregnancy rate, especially in women with CC failure. The live birth rate is more without increasing the multiple pregnancy rate. The clinical pregnancy rate is also increased, though this evidence is moderate quality. More miscarriages are there with the use of gonadotrophin. The disadvantages we have already seen is hyperstimulation, multiple pregnancy, increased cost, and increased physical and financial and emotional burden, especially if the patient doesn't get pregnant with so much of expense. Follicular monitoring in today's day and age is mandatory. There are no two ways about it. You cannot presume, you give the patient a drug and presume she has ovulated. You must, especially at least in one cycle in PCOS patients, see whether the dose that you're given is effective, whether it did induce ovulation or not. And then maybe you can give her a couple of cycles without monitoring, but it's always good to monitor, to know what the lining is like, what the follicle is like, at what is the time of your trigger. If you're doing an IUI, it's a must because you have to time the IUI. You must confirm ovulation and that it's not just a LUF that has happened. You look at the character of the endometrium and evaluate OHSS risks. So, ladies and gentlemen, I will repeat and reiterate that follicular monitoring is extremely, extremely essential when you are doing ovulation induction, because you cannot expose patients to drugs multiple times. They have their own repercussions. You can start with a baseline on cycle day 2, see that the endometrium is thin, there are no cysts there. We don't monitor E2 and progesterone levels as a routine, but these are the levels which should be there. And then you do your next monitoring around cycle day 8 or 9, and based on the follicular growth, you can do a closer or a later monitoring. And roughly after the follicle is 14, it will grow at about 2 millimeters a day. Now, what happens, what is peculiar to clomiphene and letrozole cycle is that they have very large follicles very early on in the cycle. And invariably, you find people, because it's reached 18 millimeters, it's still hardly day 8 or 9, the trigger is given. But remember that the follicle size may be that, the antrum may be that, the follicular fluid may be that, but the oocyte is not mature. And it has been seen in IVF that if the follicle, if you've given letrozole, the trigger should not be before the follicle has reached 20 mm because the oocyte maturity is not there. The perifollicular flow is good with letrozole and not so great with clomiphene. Endometrial vascularity is good with letrozole and not so much with clomiphene. Coming then on to induction, induction of the LH surge. Now the natural surge goes up 14 hours, plateau 14, and then down in the next 20 hours. And this lasts for 36 to 48 hours, basically. So 36 hours after the start of the surge, ovulation will happen. In HCG, it's a rise, a long plateau, and a long time to drop. So almost by day 6, the effect of HCG will last that long. When you give an agonist, however, you have a sharp rise and a sharp fall. Now, HCG, you can give 5 or 10,000 units, but remember, you can even get ovulation with this as low a dose as 3,000 international units. And one of the advantages of HCG is it maintains corpus luteum support because the effect is on till about day 6, so it maintains your corpus luteum, keeps the progesterone high. With the GnRH agonist, it has a shorter life. You can use decapeptyl 0.2 milligrams or leuprolide 1 milligram. It effectively gives you the surge. The OHSS is significantly lower, and you can see here, but the luteal phase is short. You'll have a defective luteal phase, and this will cut down on your pregnancy rates and increase the miscarriage rates. So when you're giving agonist, you have to give an enhanced luteal phase support. You have to give a little bit of HCG to get that corpus luteum functioning. So therefore, in routine ovulation induction IUI, please do not use GnRH agonist as trigger until and unless you have a risk of multiple follicles and high E2 levels. Should we use the agonist or antagonist? Now, we know that premature LH surge of more than 10 with a concomitant rise of progesterone of more than 1 milligrams, it should be nanograms, sorry, is, would suggest premature luteinization and premature LH surge. And this is seen in about 25 to 30 of ovulation induction cycle and also in older women. But does that justify you giving an antagonist? So it has been seen that really giving the antagonist does not change the outcome of your IUI. It does not improve reproductive performance. You need 20 cycles of antagonist to get just 1 additional pregnancy. And that's really not justified given the cost of these drugs. The agonist protocols for IUI are just not justified. There is so much of you, 21 days you're giving injections, you have to give gonadotrophins for stimulation. Just imagine the amount of financial burden on the patient, the physical burden on the patient, and then at the end of it, she may not get pregnant as well. So it is not justified. Should we monitor the LH surge in urine or blood? Remains a question. If you're doing very close monitoring, you may not need to do it. However, when you are wanting to do a donor IUI or you want to time your IUI very well, you could do a blood LH. The urine LH is notorious for being, false, giving you a false information. So far as luteal phase support goes, as I said, it is essential in gonadotrophin cycles. It's not really essential in ovulation induction cycles, but you can give either Dufiston 10 milligrams twice a day or a vaginal pessary or injectable as you like, because we've seen that it really does not benefit you except when you have given gonadotrophins. Now, can we look at progesterone levels in the luteal phase to see, do we need to supplement more? Well, this is mostly in ART that these levels have been looked at and much debated. A baseline of about 15 nanograms, higher than that, suggests that it improves pregnancy rate and decreases miscarriage rate. And we also had a paper out by one of my students on this. However, there's still a lot of debate. So the values are 15 to 20 nanograms in the luteal phase, which should support pregnancy very well. So the treatment algorithm goes letrozole drug of first choice, CC drug of second choice, CC letrozole plus GT as the third choice, and then just gonadotrophins alone. Please remember that when you're doing all these algorithms, do not forget the age of the woman. There is no point spending 1 year, then she reaches 39, 40, and then, whatever you do, really, you're in trouble. There was a move to suggest that you do low dose FSH as the first line of treatment for PCOS, but I don't think anybody took that up very seriously. When you look at PCOS, which are CC resistant, then if they're obese, lifestyle modification, non-obese, letrozole, metformin plus clomiphene, then move on to gonadotrophins and IVF. Again, age is very important factor that you must bear in mind. Now, the Cochrane 2017 again said that letrozole and CC plus metformin will give you significantly higher birth rates and ongoing pregnancies as compared to CC alone. And this has been reiterated again in the further reviews of Cochrane, with gonadotrophins giving more live births than just continuing on with clomiphene without increasing the multiple pregnancy rates. So this is the algorithm to follow when you have CC resistant patients. With inositol, there is not enough evidence available. That I think the number of studies are still low, and there may be a few years before we get any evidence of its use or benefit in PCOS, CC resistant PCOS. And the last and the final slide, which I think it's very, very important because this is a concern which most people have, is the risk of malignancy with ovulation induction drugs. Now, a literature review says, and we can reassure our patients, that fertility drugs do not appear to significantly increase the risk of invasive ovarian, endometrial, breast, and other cancers. Pregnancy is protective. However, ovarian cancer risk is increased in women treated for infertility with ovulation induction drugs, that is the subfertile women, as compared to general population. The risk is also more in nulliparas, and the risk of beauty is also more in these women. However, the studies are small, but we must bear this in mind, especially if there is a family history of ovarian cancer. You must be very careful about the number of times you're going to stimulate that woman with ovulation induction drugs. Clomiphene citrate per se, more than 7 cycles in subfertile women are associated with an increased risk of endometrial cancer. However, PCO patients as such run an inherent risk, so not very certain. However, again, in 2017, it was said that CC should be restricted to 6 cycles, and malignant melanoma and thyroid cancer risk is higher among CC-treated women in almost all studies. So yes, at the moment it's reassuring. However, we must control the number of cycles we do, and therefore whatever we do, we have to use it effectively with all the arsenal, with all the technology available. We must fine-tune our ovulation induction so that we keep the patient safe and get the pregnancy before she goes on to any complication. And if it hasn't happened within a reasonable period of time, we move her on to IVF. And with that, I'd like to thank you all very much.
Hello, ma'am. We can go for the question and answer session now.
Yeah. Okay, so the first question is what to do if premature LH surge occurs. In cases where HCG is low, empty follicle See, basically, how do you know the follicle is empty? You're only doing an IUI. We are not doing IVF. If you're looking at IVF and there's an empty follicle, we have to first look at whether our HCG was given in the right dose, whether the patient has taken it. We need to do the LH levels in blood. So one cycle, if it has happened, in the next cycle, you have to be careful about giving the HCG and monitoring the LH surge in blood 12 hours later to see if the LH surge has started and is effective. So the pure empty follicle is rather rare. It doesn't happen. And if it is happening repeatedly in a patient, then there is something definitely wrong with the oocyte quality, because it's not really that the follicle is empty, but it's that perhaps the oocyte is not good enough, and therefore it's not, the cumulus is not expanding and it's not separating out. So this is something totally different. It's related to IVF. And what should be the minimal level of LH on day 2? Now, what I would like to tell most viewers here is that PCO patients are the one where the LH levels are high. We don't look at any minimal levels on LH2 because they are what they are. We don't even do LH levels for IUI patients, except in PCOs where you have done a baseline. Now, if the baseline LH level, if the LH is above 8 and above, then you're going to have a tough time stimulating the patients. It may be better to put her on oral contraceptive pill for a couple of months, bring down the FSH to 5 or below, and then plan your ovulation induction, and it may work out better. We again don't do LH surges, but if you want to know when you know that it is going above, it's at 180% of baseline. So you need to know your baseline for that. But if you find that the LH has gone above 10, then you know the LH surge would be starting, and 36 hours after that, you will, the ovulation would happen. So the next question is by Samir. If the patient AMH level is 5 and LH level is 9 and tubal patency is okay, we stimulate this patient. I can't read the whole thing. Yes, of course. Why will you not stimulate the patient? As I again just said, that you can bring down the LH level by giving one cycle of oral contraceptive pill and then stimulate the patient. There's no problem. Sometimes LH levels really may not even come down. You can just try and see if it works. Sometimes it works, sometimes it doesn't. If it doesn't, then you will need to give her at least 3 cycles of pills to bring the LH level down, and then stimulate her. If she's obese, you ask her to lose weight. You can put her on insulin sensitizer. So there are many things you can do to reduce the intra-ovarian androgen levels. Basically, the high LH, what it's doing, it's increasing the androgens within the ovary, increasing and therefore causing ovulatory dysfunction. So that's what you need to reduce. Again, prediction of premature LH surge is by doing progesterone levels or by doing LH levels. So if the progesterone rise or the LH rise starts before your follicle is really mature for you to give a trigger, that's a premature LH surge. And as I said, in simple ovulation induction cycles, we really don't go this far because it really doesn't happen that frequently. A close ultrasound monitoring is really good enough. Sometimes, if you feel the cycle day, it's just day 11, the follicle is looking ready, the lining is looking ready. Should I give her a trigger? Should I not give her a trigger? She has a 28-day cycle. What you just do is you monitor her every day. It's a little tedious, but it's much better than putting her through LH blood levels, which may or may not come out correct. Then you have to do it again the next day because it's a serial rise. It's not a single rise. So a close ultrasound monitoring, you can just follow the natural ovulation because that will happen. You need not necessarily have to give LH. And in IUI cycles, as I just showed you, the reproductive outcome doesn't really change. What are the contraindications for? Everything is a contraindication for GnRH agonist trigger in simple IUI. Please give an agonist trigger only and only if you are having multiple follicles. There again, there is a danger. Estradiol levels are high. You're giving her agonist at that time. OHSS is prevented. But if she conceives, the endogenous HCG will rise and she will have late OHSS. So if you are in that situation in an IUI cycle where you're needing to use the GnRH agonist trigger, then safer to move that patient on to an IVF. AMH1, IVF tried twice, no follicle retrieve. There has to be something wrong with the stimulation. It is not possible with an AMH. If it is 1, if it is 0.1, I don't know. If it is 1, I don't see any reason why you should not get, you should get more follicles, but you will at least get 2 or 3 follicles. With 1, you can get even 5 or 6. So please check your stimulation, look at the hormonal profile. When you start with your injectable medication, use a good quality drug. Sometimes it's the drug which is creating the problem. And if this patient has earlier stimulated with things like clomiphene, let me tell you, and I've had few patients like this now, one of them was a doctor, that they still get stimulated more by the endogenous FSH-LH than the exogenous. So they don't do very well on gonadotrophins, but when you give them clomiphene, they form follicles. So there may be a receptor issue there. We don't know. These things are difficult to check. If she has had IUI cycles where she has had follicles with clomiphene, I would suggest you give her clomiphene in addition to giving a good quality FSH or HMG. Can HCG be given only according to the size of the follicle? If we don't, most of the time we give it according to the size of the follicle. We don't do estradiol values. But what you need to see, few things you have to see, which are important. One is that what is the day, when this follicle is, she has a 28-day cycle, but the follicle is looking 18 on day 9. The lining is still only 6 mm. So don't give your HCG. Wait for that follicle, wait for the lining to come up. And that will tell you that the estradiol level is rising and what is the right time to give HCG. You will reach cycle day 11, 12 in a 28-day cycle. That would be about the time that the follicle would be, or the oocyte would be mature within that follicle, even though the size of the follicle is high. So you don't need to do estradiol values. We don't do them in IUI or simple ovulation induction cycles, but we do look at the cycle length that the patient has. We look at the endometrial lining. Is it in sync with the size of the follicle that is there? And is it matching to the day of her cycles? We definitely do closer monitorings. And because we do closer monitorings, our judgment then for giving HCG is based on that rather than estradiol values. You can't diagnose premature LH surge by scan. Right? It's not possible, unless I suppose you are a very, very sort of super ultrasonologist. Even they can't really diagnose the surge, but they can see certain features within the follicle of, the echogenicity increasing or whatever, which could probably indicate, but it cannot be confirmatory. When CC is used, what is the actual? The same dose. You can use 50 mg of CC and 2.5 of letrozole. Then how? No, monitoring in a family history of ovarian cancer, monitoring doesn't change. Monitoring will remain the same. You just ensure that you do not do repeated stimulations for that patient. If when you're giving clomiphene or letrozole, you find that the patient has cystic follicles, please do her CA125 and move her on to IVF straight. Do not go on and on. It's the repeated stimulation, the repeated epithelial breaks, which are going to increase her risk. Absolutely, with 5 and 10,000 of HCG are perfectly okay. We give 5,000 very, very routinely when I've just given a simple ovulatory drug like clomiphene or letrozole, I don't necessarily go in for 10,000. 10,000 actually gives you a bit of luteal support also. And thank you for the nice comment that you've given. What is your, to tell you, Dr. Surinder Singh, I have barely ever used the two together. In fact, when, the first, not literature, first personal experiences of Indian doctors came out with this, I used to wonder how it's going to work. But what I have generally done is if CC is not working, I've added letrozole in a PCOS patient. So I've used it like that. I have never really used it together, to be honest. I've not used it together. When using, you have to give both together in the same dosage schedule that you would use. So CC 50, letrozole 2.5. If you want to give CC 100, letrozole 2.5, there's no fixed schedule to these doses at all. You have to see what is bringing your FSH to that threshold value, which will start increasing or recruiting the follicle. Even after HCG, if no ovulation, what to do? Well, what I would say is, one, that the HCG has been given earlier than when it should have been done. Unless you have cytoplasmic and nuclear maturity in the oocyte and you have a cumulus which is ready for expansion, you can give HCG and nothing will happen. In fact, if your progesterones have gone high, the LH it's a luteinized follicle, you're not going to have any ovulation. However, there are two things to remember here. One is that when you do not keep monitoring the woman, you've seen 36 hours later, nothing happened, you give her another shot and you let her be. Frankly, if you keep monitoring that girl without even repeating the HCG, you will find that at some point when her body is ready, her surge will happen and ovulation will happen. Now, whether that oocyte is good enough for fertilization and inducing a pregnancy, I cannot say, because we have interfered with the endocrinology of the cycle. We have given an LH way before it was to be given. That's a tough call. But that's why I'm again and again repeating, don't be in a rush to give HCG, because her surge will also happen automatically. Even if you're a little late in giving HCG, there is no problem there. Again, for management of repeated unruptured follicles, I would like to say it is the same story. They do not rupture because HCG is given before time. You monitor this woman. If she is an unexplained infertility, please monitor her in a natural cycle and you will find she has beautiful ovulation. So it is the timing of the HCG that you're giving which is wrong, and that is why the follicle is repeatedly unruptured. The only condition where you sometimes do find these repeated LUFs, two conditions I would say. One is endometriosis, where it can happen, and if that is happening, move the patient on to IVF. The other is pelvic adhesions. If you have very bad pelvic adhesions, then sometimes you will find this. Again, the answer is to move them to IVF. So same question, so it can be 5 or 10, whatever you feel like. If there are more than 4 follicles growing in ovulation induction or AIH, would you abandon? Well, with 4 follicles, I'm definitely not going to convert to IVF, because IVF is a costly procedure and the patient ends up spending money. Suppose out of those 4 follicles, you get 2 eggs, then patient's money is down the drain and she gets upset. So I would either cancel the cycle completely or take my chances and go ahead giving her an agonist trigger, in which case her chances of pregnancy may be a little lower. But please do the estradiol levels. If the estradiol levels are high, then cut it out. Please don't give anything. Just abandon the cycle, otherwise you'll be in trouble. If endometrial thickness is less at day 14, what to do? Well, depends on what is her endometrial thickness in a natural cycle. If her natural endometrium in her natural cycle at ovulation is, say, 6.57, well, that's what it's going to be. That is the nature of her body. So don't push it. That doesn't mean the endometrium is not receptive. You can add external exogenous estrogen if you want. Whether that's really helpful, is debated, but you can add that. But let me tell you that you will get pregnancies in endometria which are 6 and even less than 6. But monitor the natural cycle to see how her own body and how her own endocrine system is functioning. And if that is showing the same thickness, investigate, see that there is no tuberculosis, cavity is normal, there are no septa or other thing. Other than that, please leave her alone. What should be the female about? For ovulation induction. Now, if you're talking about IUI, there is no female age above which, if she has an AMH level, if she has an AMH level which suggests that there are, and you see antral follicles, and the patient wants to go ahead, you can do it at any age. But you have to tell the patient that above the age of 40, because she's going to have over 90% of her eggs abnormal. Above 43, she's going to have more than 95% of her eggs abnormal. Her chances of conception will be low, but taking a tablet to induce ovulation is no big deal. She can have it. If you're having more than 7 to 8 follicles and you're planning to do IUI, please cut it out, don't do it. Role of antagonist in IUI I've already discussed. Dose of antagonist doesn't change, it remains the same. But as I told you, you should only do it if you're thinking of, if you have some time constraint, you have to time your IUI to a particular time, you have, it's falling on a Sunday and you want it on a Monday, or the patient can't come on a particular day. But extending your surge beyond a day, if you're delaying the HCG beyond a day, then you're going to be in trouble. The outcome is not going to be very good. 1 day is good enough. If you actually prepone HCG, as we have already discussed before, if you prepone HCG, and this has been seen in IVF cycles, the outcome is never good. You'll have more immature eggs coming out, and the fertilization, pregnancy rates, everything is completely altered. Safest dose to start with is 37.5, and you slowly titrate up by 37.5 for a breakthrough. Patient has previous history of OHSS. Please, I would suggest you take her up for IVF, because with IUI, you will get into trouble. As soon as if she gets pregnant, endogenous HCG will start getting secreted, and you will be in trouble handling that ovarian hyperstimulation syndrome. I don't understand. What about giving single dose of antagonist to reduce LH in early? Well, you can do it. But as I said, that for simple, what are you trying to achieve with reducing LH? You are trying to achieve a decrease in intra-ovarian androgen levels. 1 day of reducing the LH is not going to alter your intra-ovarian androgen. That is why you give OCP, because through that it also has anti-androgens, and it helps to reduce the LH and the androgen level. LH level will come down with an antagonist, but you're not going to change the endocrine milieu of the ovary. Thank you very much, Dr. Is it Preeti Primit or Sutha Jyoti? For the compliment, but cabagulin I will only give if the patient's prolactin is high. Melatonin I very rarely use. I mean, to be honest, I've never even used it. I've never found the need to use melatonin yet. Many times I've thought, but the reports are so contradictory that I don't know whether it's worth doing it. Cabagulin, if prolactin levels are high. Another thing that I would like to tell you about cabagulin is about prolactin levels are, you may get a high prolactin level, but please do a pooled prolactin before you put the patient on cabagulin, because very often you'll find the prolactin level is 30, 35, 29, and the patient has been put on cabagulin for what? You need prolactin receptors. You need those receptors there in the endometrium for a good outcome. Now, if you're going to wipe out the entire prolactin from the body by giving cabagulin to somebody who doesn't need it, it's not going to augur well for your cycle. What oral do you prefer in minimal? I use tamoxifen, that is my favorite. What would be the safest dose in again, as I said, This I already answered this question about previous OHSS. Yes, combined treatment is for 5 days. So thank you again for the compliments. In case day 2 LH is high, would you prefer to give antagonist or a pill in IVF cases? I would prefer to give a pill one cycle before I go on. And that is if it is high beyond 7 or 8. If it is in the range of 4, 5, it's going to remain like that. And so therefore there is no really need to start dosing the person with extra medication. But yes, if it is a high LH like 7, 8, then I would prefer to give OCP at least for one cycle or two, if possible, before starting IVF. Monitoring IVF cycles is exactly the same as the IUI cycles. In fact, we monitor equally judiciously. And but you have to do in IVF cycles. We will start with a day 2, at least estrogen or progesterone, if we feel that there is a corpus luteum sitting there or a larger follicle sitting there. Otherwise, straight on the day of HCG, we do the estradiol and progesterone levels. In between, if the follicles are not growing well, then I would like to do the estradiol levels to see, do I need a dose increase, why the follicles are not growing. When do patients need ovarian drilling in PCOS for ovulation induction? Well, you know the indications for that. It's now a third line, so to say, treatment. But there are patients, especially in our country, who are living in villages who can't come repeatedly for medication and monitoring, where those people would definitely do well with drilling, so that at least for a few cycles they will be ovulating on their own. About 3 to 4 IUI cycles are recommended before moving the patient on. However, please remember age is the most important factor. Don't give 3 IUI cycles to somebody who's 39 years old, because then by the time she's 40, everything in any case gets over. It is said that IUI see again here, Subi, what I would say is that what we do here, I mean, I know that people have this 36 hours stuck in their mind. If we are worried that the follicle may rupture the next day, and the size of the follicle, the blood flow, the cycle day will give you an indication, or if we are worried, we do the LH level and that seems to be rising, then we we call the patient the next day and do the IUI on that day. Because doing an IUI earlier is far safer and better than doing an IUI after ovulation, because the sperm lasts for 48 to 72 hours or even more. Whereas the egg, the maximum good fertilizability is within 12 hours of ovulation. So doing an IUI before ovulation is far better than when ovulation has occurred and you really don't know how many hours have passed by. But if you want to fine tune, then you need to do the LH. If the LH has not risen, then safely you can assume that after giving HCG, it will take 36 hours before rupture happens. Sometimes it takes even 40 hours. We use antagonist protocol for PCOS. It is the recommended protocol for PCOS patients because it reduces the ovarian hyperstimulation chances. And you can use GnRH agonist to trigger. I don't use sildenafil. I'm never required to it, and endometrial thickness happens. Nice lecture. Thank you very much. Can FSH be given in higher? Again, I've told you, repeatedly, Cochrane has said that it doesn't matter. You can use any preparation of HMG to induce ovulation. High LH, low LH, PCO, everybody you can use it without a fear that one is better than the other or one is worse. Sorry, I didn't understand. Instead of, can FSH be given instead of OCP? I didn't understand this question. Can you please, elaborate a little? Is tamoxifen better than letrozole? Well, nobody has really done a comparison, and there are very few studies with tamoxifen. But frankly, I prefer it, and I use it almost exclusive. I mean, this is my drug of first choice, is tamoxifen. because it gives a beautiful lining, endometrial lining. Urinary LH kit is notorious for being wrong, so I really don't advocate it at all. But you can, patient has to do it every day or sometimes twice a day. FSH is 900. Please put this patient onto oral contraceptive pill for at least 3 cycles and then repeat the values before you do anything further, because with this LH value, nothing will happen. And she may be needing, insulin sensitizers, etc. Even medroxyprogesterone can be a good option to reduce. Yes, definitely it can. Even in IUI samples, the sperm is going to last more than 24 hours. If you process a sample and you keep a little bit of your processed sample in the lab, in an incubator, you will find next day you look at it, you can see motile sperms. And that is, in fact, one of the ways we used to do to check for, our incubator and lab efficiency was looking at sperm survival. I think I've answered this dose of HCG. It's 5,000 is good enough, but 10,000 also gives you luteal support. If you have a follicular cyst on day 10, day 2 of cycle, then of 1 to 2 centimeters. When you 10 mm is fine, but 20 mm follicle, you will rarely find the E2 less than 50. However, you're just doing ovulation induction, it's okay. But remember that you can give the drug, but the cyst is going to get enlarged. So as a rule, if we have anything over 10 or 11 mm, we don't give ovulation induction, because invariably you'll find that the cyst starts getting larger. We rather just look at a natural cycle and ask the person to have timed intercourse at that time. No, I don't understand how FSH is going to bring down LH, Meenakshi. Can you explain how will FSH bring down the LH levels? Dexamethasone is again a drug which I don't use a lot of, but sometimes when you find in patients that their androgen levels are a little high, and that too not really, I don't necessarily do androgen levels that much, but when you find that the ovulation is not proceeding as it should, the follicles are not growing, the lining is not looking good, patient has a lot of hirsutism, I may add in those patients dexamethasone for that particular cycle or for 14 days in the cycle to bring down the adrenal androgens so that the cycle goes better. Paritosh, again, with this FSH, with this LH, please put the patient on oral contraceptive pill for 3 cycles and then see what the LH levels are and what is the weight of the patient. Put her on glycomet to also try and bring down the insulin resistance, so that the internal environment or the endocrine milieu within the ovary improves before you start stimulation, because with LH of 30, nothing is going to happen.
That's all with the questions. So I'll just request you for a takeaway message for the doctors, ma'am.
Oh, okay. So the takeaway message here is that, one, understand the endocrinology. When you use your drugs, know what you're using, know what it is doing to the body, monitor closely, watch what's happening within the cycle, because that will give you information for the next cycle and how best to use, what drug to use, when to give your trigger, and when to time your IUI. So close monitoring actually is the most informative of everything else. And thank you very much for all of those who have appreciated the lecture. Thank you so much.